brachycephalic patients, and that will be led by Dr. Shani Irafish. Dr. Shani graduated from Cornell University in 2006. He then did his internship at Angel Animal Medical Center and then 2 one-year small animal surgical internships at Long Island Veterinary Specialists. Thereafter, he did a small animal surgery residence at Long Island Veterinary Specialists in 2012, becoming a diplomat for the American College of Veterinary Surgeons. Dr. Irafish has operated in numerous multi-specialty and emergency veterinary hospitals across the United States, as both a surgeon, hospital owner, and chief medical officer. He is the creator of Vet Triage and currently serves as their chief medical officer, focusing on clinic and hospital partnerships to aid the teletriage and telemonitoring, promote excellence, virtual care as an extension of those facilities, and helping with work-life balance for those partnered facilities. Without any further ado, let us give a warm welcome to Dr. Shani Irafish.
Okay, hello, good morning everybody. How many folks here are veterinary students? Nice. And how many folks here are recent graduates, like in the past 5 years? Okay, good. Perfect. So this is Brachycephalic Obstructive Airway syndrome. And that's my background, you just heard. We're going to go over a variety of topics here. This is tailored for the folks that are just getting into veterinary medicine or don't have a lot of experience with this. I do realize that this topic, a lot of folks in the audience may have extensive experience with it, and I also do realize that a lot of folks have different ways of managing these cases. So there's no one right way to manage these, and I'm open to any opinions that individuals have, because this is the kind of topic that has a lot of variety to them. So in brief, when we look at defining the syndrome, you can categorize it by a number of diseases. This is just a small list of what is possible with these dogs. So I just listed here the most common ones. Typically, we think of Brachycephalic Airway syndrome as having elongated soft palates, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, laryngeal collapse. But there are many more conditions, and the more you perform a literature search on this condition, the more you realize how many of these dogs are affected badly with other pathologies. So it's tough to say where this disease begins, but most of us believe that the problem begins with the nares. And so they have stenotic nares that they're born with, it's congenital, and that creates an increase in respiratory turbulence, increased respiratory pressure. And that increased pressure from the nares affects the dogs downstream. And so over time, whatever time means, over time, that increased airway resistance, that turbulence, will result in a thickened and elongated soft palate that over time create issues with the tonsils and the saccules. That'll also affect the laryngeal region, and then downstream you'll have effects to the trachea, the bronchioles, the lungs, the heart. And so it becomes this chain of events that maybe all begins with stenotic nares. And so if that's true, in theory, if you were to treat these dogs for their nares early on before they develop the other conditions, hopefully maybe you can prevent the other conditions from developing, or at least if they're going to develop, maybe they'll develop in less severity. So that's typically what we think of with these dogs in terms of the pathophysiology behind it. So here's a picture of everted saccules there behind the arytenoids, and here's the example here with thickened palate and inflamed cartilage here with the arytenoids. So this is some of the examples that affects these dogs. When you look at them a bit deeper, if you have the opportunity to run computed tomography on them, CT scans, you'll notice that compared to a normal dog, the brachycephalic dogs have a compressed nasal cavity, they have abnormal turbinates, and so there's a lot more happening underneath the surface that we can't see with just a physical examination or a sedated oral laryngeal exam. And so the reason why I'm bringing this up is not to necessarily recommend that every brachycephalic receive a CT scan, but it's to make you aware that there are lots of other abnormalities that we are not appreciating with these dogs. And so if you wonder why some of these dogs don't recover well after surgery, it may be because they have underlying issues that have not been diagnosed yet, or they have underlying issues that have not been fixed. So just be aware of these things. As a surgeon, I almost never am running CT scans on these dogs, but at the end of the day, these are things that maybe with future studies, which have already been published, maybe there's some way of correcting these conditions. We'll see. And of course, you can see here the severity of brachycephalic dogs. They're not all created equal. There's different severities of them. And so that also complicates this condition. This is an example of the turbinate, caudal abnormal turbinates here with these dogs. So they'll have these tissues, these growths in the nasal cavity that's also adding to the upper airway obstruction that these dogs have. And then if you look downstream as well, these dogs frequently would have either hypoplastic trachea or redundant dorsal tracheal membrane. And that's going to compound this condition, causing more lower airway issues. And that's when you see bronchiolar collapse and bronchopneumonia and cardiovascular disease from these dogs downstream. The other important thing that we don't really investigate as much as we probably should is gastrointestinal disease in these dogs. I guarantee you, if you were to go into a deep dive with the history of these dogs, you'll find out a lot of them have chronic, fluctuating GI disease. Now, whether or not that GI disease is a separate entity to the respiratory disease or they're related is difficult to say, but there is a correlation between brachycephalic and concurrent gastrointestinal disease. And the reason why this is important is because the GI disease in these dogs may contribute to their prognosis. And if you tackle the GI disease in addition to their upper airway issues, you have an improved prognosis with these dogs. So we have to investigate this in a bit more detail. And you have to do a deep dive with the client. You have to really investigate the history to find out if they have any history of GI disease. So we see things like megaesophagus, for example, and this is not due to a neurologic condition, it's due to reflux esophagitis, because they have things like pyloric stenosis, they have things like sliding hiatal hernias, they're prone to gastric distal motility, and all these things causes esophageal reflux, and then you have a secondary megaesophagus. And this combination of events can occur either individually or in concurrency in the same dog. And again, whether or not this is related to the increased respiratory pressure that's occurring from these dogs upstream, difficult to say, but it's very suspicious. So the theory is that with all the upper airway resistance they are facing, their gastrointestinal tract is being affected secondarily. So it's very important to investigate these dogs for this condition. We all are aware of the clinical signs with these dogs. They're snoring, they have loud breathing, they can come into you with severe upper airway obstruction. So that's pretty typical there. And of course, in physical examination, you're looking at the nares, that's most obvious for these pets. And you can even grade the nares if you're interested. These are grading systems that we like to use to make sure we're all on the same page when we're trying to describe the condition in dogs. So the nares is where it all begins. And then from there, you work up the patients. And radiographs for the skull are not maybe that useful for them, although sometimes you can see a soft palate in these dogs. But of course, you're going to want to have a sedated oral laryngeal exam to confirm that. The proceedings that you have for this lecture has a lot more detail than we're going to go through here. This is more clinical, but measurements are in your proceedings with trying to figure out if these dogs have hypoplastic trachea or not, because that can be something that's very difficult to diagnose on radiographs without actual measurements. And then, of course, you're going to have thoracic radiographs as part of your workup for these dogs. You're looking for not only bronchopneumonia, but things like megaesophagus and concurrent cardiac disease. Those are all conditions you want to screen for with these dogs with the lower airway examination. And as I mentioned before, CT scan is more of a, just so you know, it's not necessarily part of a routine workup for these dogs, but I want you to be aware that we do see abnormalities in the nasal turbinates, and we even have a grading system for that should we investigate these dogs further. Laryngoscopy is going to be the second most important thing. After you diagnose the stenotic nares, which is going to be fairly obvious, you want to document what's happening in the upper airway. And so with some light sedation, you're going to evaluate the laryngeal cavity, and you're looking for any abnormalities here. And you're looking for any evidence of laryngeal collapse. Laryngeal collapse is really difficult because it does affect the prognosis, and a lot of it can't be repaired, especially in advanced stages. So stage 1 is typically the everted saccules, which is what you can see here behind the arytenoids. You see these puffed up pink structures, those are the saccules there, and they're contributing to the upper airway resistance that we're seeing in these dogs. And after stage 1, over time, they can progress to stage 2. Stage 2 includes stage 1, and now it's involved in the cuneiform process of the arytenoids. And so you end up having arytenoid cartilages that are erythematous and edema, and they're of course contacting each other, which worsens the cycle, which contributes to upper airway obstruction and creates a vicious cycle. And then stage 3 is the most advanced stage, which includes stage 1 and 2, and now you're involving more of the arytenoid cartilages and contributing to that laryngeal collapse. So this really affects these dogs over time, and this is why you want to diagnose these conditions early and have surgical intervention for these dogs early on, so you can prevent laryngeal collapse from forming. And here we have again another grading system to become more objective when you're trying to work up these dogs. There's a classification system for laryngeal collapse that we just reviewed, and so here's a picture documentation of that. And you can see how severe this is. I mean, these are dogs that they're really difficult to reverse. You're not going to reverse laryngeal collapse, but it's very difficult to get these dogs back to a quality of life. And so you're trying to prevent this from happening. And then if you're fortunate enough to have internal medicine in your hospital, or that you can refer to as a surgeon, I'm not performing the scoping, but internal medicine will. And so you're looking at the lower airway, you're looking at the trachea of these dogs. Do they have hypoplastic trachea or dorsal tracheal membrane redundancy? That's affecting their airway resistance. And further down, you look at the bronchioles to see are those bronchiolar lumens collapsing on these dogs as well. That's all contributing to this disease. So it's not necessarily customary for all of these dogs to receive scoping. I just want you to be aware of that the workup of these dogs can be quite extensive. And depending on what you have available to you with higher end diagnostics and what the pet owner wants to do, you could really screen these dogs for multiple comorbidities. And then of course that affects prognosis as well. Now medical management is a whole other topic, which I'm happy to go over in more detail. Of course, the main goal with these dogs, if they're coming to you in a crisis to stabilize them, you want to get them in oxygen. And this is just a slide to remind us that there are many different ways of administering oxygen for these dogs, some better than others, but in a crisis situation, you're trying to stabilize them, you want to get oxygen on board for these pets. And then while you're trying to stabilize them by getting their pulse ox improved, you're trying to sedate them. And while you're sedating them, you're not only sedating them for therapeutic reasons, but you're trying to sedate them for diagnostic reasons as well, because you want to perform that laryngeal examination. And so you're performing two things at once. You sedate them so that you can stabilize them and get their airway under control. You want to capture the airway. So typically sedation, laryngeal exam, intubate them, and then have them on a continuous rate infusion of whatever drug you want to keep them sedated so you can further stabilize. Get their temperature down, get their oxygen levels up, you're monitoring blood pressure. And so this is what you're trying to do with these dogs if they're coming to you in a crisis. Most dogs hopefully are coming to you with just standard loud breathing and snoring, stable dogs. These are dogs who are in a crisis. And so in that scenario, you have plenty of different drugs you can use depending on your experience and what you're used to sedate these pets and also diagnose the condition at the same time. And then while they're in the back end of the hospital or in ICU, depending on where you work, you can then go talk to the pet owners about what you found so far with these dogs and what you think needs to happen. And ideally, you want to stabilize them before surgery. Sometimes you just can't. Every time you wake them up, they go into respiratory crisis. Then you have to resedate them, re-intubate them, and start all over again. So sometimes these dogs need surgery on an emergency basis that are coming to you quite critical. And of course, these are the dogs that are coming in because they either have advanced disease or something set them off. Maybe it was very hot or humid that day, they didn't drink enough water, they were playing really hard, it was summer outside, and so they end up going into this anxiety-filled crisis, whatever the situation may be. Now these are different drugs that I'd like to mention because I have a unique take on this, and so I'm interested to see what the audience thinks about these medications. So I'll just talk about these in brief. I'm a huge fan of metoclopramide. A lot of these dogs do have gastrointestinal dysmotility and esophageal reflux, and that reflux may make them more prone to bronchopneumonia. And of course, you're performing anesthesia on them, which worsens the chance of esophagitis and having regurgitation and then bronchopneumonia developing. So, motility drugs like metoclopramide, like Reglan, are really useful, I think. And typically with these dogs, especially if they're badly affected, I will not only start with a bolus of metoclopramide at induction, but I also will sometimes have them on a continuous rate infusion of metoclopramide. That's not in the literature as far as I know for this condition. It's what I use over time as a surgeon because I tend to see the cases that are most severe. And so over time I've developed techniques that I'm very happy with. So metoclopramide is a really good drug to help move the gastrointestinal contents along to try and prevent that bronchopneumonia, which of course is a terrible complication of this disease. Cerenia has been a very popular, not only anti-nausea drug, but in addition to your anesthetic protocol. And so Cerenia has done wonders for these dogs as well. Any dog under anesthesia, but especially these pets, because we are trying to prevent regurgitation and vomiting, because these dogs are so prone to bronchopneumonia. I mentioned here antibiotics, not because you necessarily need them, but because if you feel that that case requires antibiotics, I like to use something that's a bit more benign on these brachycephalic dogs. It's going to be hard to get these dogs to ingest oral medication when they go home. And the less medication you can give them, the better. And maybe you're sending them home with anti-inflammatories or analgesia or sedatives. That's a lot of pills to give a dog. And so if you're going to add antibiotics to it, if you think it's indicated, then something like Simplicep, cefpodoxime, which is a once-a-day drug, maybe that's the way to go, or preferably even an injectable drug like Convenia that'll last 10 to 14 days. I'm not saying these dogs require antibiotics. Most of them probably don't, unless you're dealing with bronchopneumonia or some other comorbidity. But if you're going to cover them with antibiotics for something that's not that severe, but you want antibiotic coverage, it may be worth thinking about a drug that is easy to administer, either as an injection once in the hospital or a once-a-day drug, because like I said, we want to minimize the oral intake of pills for these dogs post-operatively. So just some thoughts. That's why I said at the beginning of this talk, there's a lot of nuance to this and a lot of individual experience levels to decide what you want to do with them. And then part of your procedure for dogs that are coming to you that are critical, especially if you're having a hard time intubating them because there's so much laryngeal edema, you may have to perform a temporary tracheostomy. And this is something that if you in your practice deal with a lot of these dogs, this is easy enough to try and practice on a cadaver if you have access to that and see whether or not it's something you feel comfortable doing. It's a very powerful procedure as a means to try and bypass the upper airway. And so this is a nice way of stabilizing these dogs if you aren't able to intubate them for whatever reason. The temporary tracheostomy is something good to practice on a cadaver first, make sure you're comfortable with it. It is a little bit annoying because you have to have special endotracheal tubes for these, and there's a lot of maintenance for dogs to have tracheostomies. Maintenance in the hospital, and as they go home with a permanent trach, there's a lot of maintenance for the owners, to clean the stoma and make sure they don't get mucus plug. So this is a whole world to dive into, but if you see a lot of these dogs and you're struggling with referring them to a surgeon or you're seeing them on an emergency basis, maybe this is something that you want to be able to learn in the hospital so that you can have another means of stabilizing them for upper airway obstruction. Just a thought to have. And then I do want to speak a little bit about laser. As a surgeon, I wasn't really trained in laser procedures for conditions like this. But in learning more and more about CO2 lasers, I think they're very, very useful, especially for brachycephalic dogs. And so the benefits of laser therapy these days is that we are in an ideal realm of frequency here, whereas back in the old school, when I was doing my surgical internship and residency, laser would cause so much thermal damage to these pets that nobody really liked it. We didn't really catch on. But now the laser therapies are so much better with these dogs that you get minimal collateral damage. I'll show you some videos on that. And then of course there's surgery. So there's different ways of repairing the nares. You're trying to go from stenotic nares to open nares as well, right? And then after you repair the nares, typically you're going to do this part first. You then set the dog up in preparation for their oral surgery. And this is the typical routine procedure for this. So this I want to show you folks the difference between a scalpel surgery for nares resection versus the CO2 laser for them. You can see the difference here in terms of hemostasis and of course how quick the surgery is. Some surgeons don't like this surgery on brachycephalic dogs because it can be a bloody surgery, it can be frustrating. You don't have really good visualization, there's bleeding, and it's difficult to work in that small space while they're also bleeding in the surgical field, whereas laser therapy, or laser surgery rather, you've got a nice clean surgery, it's much quicker, and you have good cosmetics as well. So for folks who do a lot of these surgeries who have not dived into laser, I recommend learning about laser and having a representative come to your facility and talk to you about it. And laser also is helpful for the palate. So typically with the soft palate resection, you're going to diagnose the condition first, you're going to preemptively measure it. Now this drawing is not very accurate, it's a bit excessive. Your goal is to have the tip of that palate reach just the tip of the epiglottis. That's your goal. And so that area where you're going to cut is very important, because if you cut too much, of course you're making these dogs prone to nasal reflux, which is going to make them more prone to bronchopneumonia. So you'd rather stay a little bit on the longer side than the shorter side. If you're not sure, with experience, with time, you'll know where you want to make the cut. Ideally, you want the tip of the soft palate to be right at the level of the tip of the epiglottis. That's your goal when you cut these. And the old school method is the cut and sew method, shown here, which can be a very frustrating procedure with a lot of hemorrhage, and you need a lot of experience to do this. I grew up with the ligature, which is phenomenal. It's so easy to transect the soft palates with the ligature device. For those who are not familiar with it, this is a bipolar sealing device. It's a large cautery system. It's phenomenal. But the problem is, of course, it causes a lot of collateral damage to these dogs. And so here's an example of using a ligature to resect the soft palate in a dog, and you can see all the collateral thermal damage that's happening. All this white tissue, you're causing damage to the surrounding tissues. But compared to the cut and sew method, there's no bleeding. It's very quick. You just have to have the equipment for this to do it, which means you have to have a practice that does a lot of surgeries that can make use of the ligature. But you can see here, you can even trim it further. If you didn't really like how the cut went, you can go back in with the Alice tissue forceps, grab the extraneous tissue, and ligature some more. Or harmonic scalpel, or whatever device you want to use, and try and have a combination of hemostasis and cutting. And then an example with laser. So with the laser, you can actually preemptively mark where you want to make your cut before you start cutting. Whereas the traditional method of cut and sew, you're going to have a lot of hemorrhage, a lot of swelling from that trauma that you're causing with the scissors. You can see how quick and easy the laser is. And so for folks who do a lot of these surgeries, I recommend learning about CO2 laser. It's awesome. It makes the surgery look bad. It makes the surgery so much quicker versus the cut and sew method, which I'm sure folks are very good at this method. We've done it for many, many years, but it's a lot of work, a lot of swelling, a lot of hemorrhage, and you can do something much simpler with a CO2 laser. And this is just showing that with the CO2 laser, you can mark where you want to cut before you cut. So that's pretty cool. You can connect the dots here and decide, okay, am I happy with that? Is that where I want to go? And then that's what you aim for. One thing I'm going to mention here, let me see. Yeah, there's the CO2 laser. So I'm going to mention here a couple of things. When you have the dog in sternal recumbency and their mouth is open and you have the endotracheal tube in there and you're retracting the tongue to try to look at the soft palate, it's going to affect where the anatomic placement of the palate is. If you're holding the tongue, pulling it towards you with their mouth open, and then you're looking at the palate, that anatomy is distorted. It's not the natural anatomy. So what you typically do is you try to relax retraction of the tongue, close the mouth enough so you can still see through it, and look at what the actual palate, where it's naturally positioned. That's a better way of gauging where you're going to make your cut, rather than pulling on everything and distorting the anatomy. Because you're going to end up cutting too much if that's the case. So sometimes I have to extubate these dogs, close the mouth just enough so I can see, let go of the tongue, and look, gauge how I'm going to make my cut, mark it, and then re-intubate them, open the mouth, and then cut from there. So you want to be careful with the anatomy there, make sure you know where your plan is. And of course, laser surgery can be done for many other different procedures as well, if you decide you want to dive into that world. Now, the everted saccules, over the years, I've stopped cutting these. I'm not convinced that they contribute a large amount to the increased respiratory effort for these dogs. And also, I've seen a lot of these after I resect the nares and remove the elongated palate. that these things tend to resolve. And so over time, I've been doing less and less of this. So I'm sure other folks have different opinions on it, but over time with the saccules, I've kind of been leaving them alone. And then this slide is to show that for some conditions in these dogs, you can't fix them. If they have hypoplastic trachea, we don't have a good therapy for it. I've seen cases anecdotally that have placed a tracheal stent for hypoplastic trachea. I don't know if that makes any sense, but it's a salvage procedure. If the dog is suffering and you've done all the other procedures you can do, maybe something to consider. I don't know. This is not published data. This is just a handful of cases that I've seen where it was a salvage. You're trying to save the dog's life and there's no other operation you can perform. And the same thing goes with the laryngeal collapse. You know, what if you performed a tie-back surgery on that? Maybe it'll help them. I don't know. What if you performed an arytenoidectomy, partial arytenoidectomy, to open up that laryngeal cavity? Maybe it'll help them. I don't know. These are dogs where you've done every other procedure and they're still coming back in respiratory crisis with a severe laryngeal collapse. Maybe we have to do something for them. And so it's just thoughts to have. Again, I'm not recommending these. These are extreme cases where you have no other option other than euthanasia because these dogs keep on re-obstructing. So just thought I would throw that out there. Complications, we mentioned multiple times, bronchopneumonia. That's a concern with these dogs. Laryngeal collapse, because you can't really fix it other than maybe salvage procedures, but even that's very questionable. And then of course, sometimes these dogs need a permanent tracheostomy stoma in order to survive. And that might be the ultimate solution for the dogs that you've done everything you could do, and they're still coming back to you with a problem. They've got hypoplastic trachea, laryngeal collapse, there's nothing else you can do for them, and the pet owner doesn't want to euthanize, which is fine, then you have to talk about a permanent tracheostomy. Overall outcome for these dogs, based on the literature, improvement. We see the majority of cases. Mortality is fairly low, and the recovery, this is based on, I think, on an owner survey. 6 months post-op, owners will say their dog is excellent after surgery, and 65% of cases, good, 25%. About 1 year post-op, half the dogs are doing excellent, the other half are moderate, and then 1 year post-op, very low, poor. So a pretty good success rate overall. And I think with pet owners now being more proactive, especially with the younger generation, they're investing way more in their dogs. And so if we're able to see these dogs early on, at the early stage of the disease, maybe these numbers will improve. And then if you look at gastrointestinal disease, if you tackle their upper airway, their GI disease will improve. And if you treat both GI and respiratory, you see an improvement from 68% to 89%. And so my go-to therapy for dogs that have chronic GI disease that are also brachycephalic, have Brachycephalic Airway syndrome, I at minimum have them on long-term antacids. I usually use omeprazole for these dogs, and I'll do like a trial, maybe like a month, and see how that goes. And they might be on it forever, because a lot of times these dogs, you can't fix every single condition. And if you can't fix every single condition, they still may be prone to having gastrointestinal disease long-term. And so I like to at least have them on proton pump inhibitors to try and help improve their outcome. But you can also do things like feeding them slowly with meatballs or hand feeding them, that also works. Maybe you go to canned food instead of dry food to minimize the dust and debris from kibble entering the lower airway. Maybe feed them a little bit more upright, right? So you can do things to help alleviate the GI disease for these dogs, because we don't have a good answer for it, but we see an association there. Now, there are some prognostic factors, these are just some. The preceding you have way more prognostic factors, but potentially early surgery might improve the prognosis. That makes sense. Whether or not their younger dogs are better than older dogs, it's questionable. Although in my experience, definitely younger dogs have a better prognosis. The older dogs, when I see a 13-year-old English Bulldog, and they have very thick palate and laryngeal collapse, and always other diseases with it, arthritis, skin issues, heart disease, it's a mess. And so it makes sense to me the younger dogs are going to have a better prognosis, but the literature is questionable on this. Laryngeal collapse worsens the prognosis. Having hypoplastic trachea, having bronchopneumonia, any other concurrent airway disease, having GI disease, all these things worsen the prognosis. So the earlier you can catch these dogs, the better. And then There's talk about traditional multi-level surgery, meaning do you fix every single abnormality you see, or do you fix what's pertinent? That's difficult to say, and up to the surgeon's experience as far as how aggressive do you have to be with these dogs overall. Now, common questions that I get from this, how early can surgery be performed? And my answer is I still don't really know, although most of the doctors I've spoken to that perform this procedure on a routine basis, they will try to combine this with a spay or neuter. So whenever you're spaying and neutering them, they'll resect the nares at the same time to try and prevent those secondary sequelae. How many folks here perform brachycephalic surgery in their practice? Okay. And how many folks here will recommend this surgery early on during like a neuter or a spay? Yeah, a fair amount. Okay, yeah. I mean, that seems to be what I see as like the earliest. The literature does have earlier than that, but as far as clinical practice goes, it makes sense if you're going to anesthetize them for a spay or neuter, and they have a stenotic nares and maybe signs of elongated palate. Maybe it's worth intervening with that at the same time. So that might be the answer to that, is do it at the same time as the spay or neuter. And if you're not comfortable with these surgeries, then maybe they get the spay and neuter done at a certified surgeon's hospital. They have both things done at the same time. It's up to you, up to the pet owner to decide what you want to do. What do you do about concurrent procedures? So a lot of times the surgeon, I'm seeing critical cases that need surgery right away, and the owner asks me, well, can you also remove the mammary gland tumor? Can you remove this lipoma at the same time? Can you do these other procedures and in a critical animal? And so what I tell them is, yes, but I have the right to abort mission. If I don't want to do that extra procedure because the patient is not doing well under anesthesia, we don't have that luxury, I tell the pet owner, I'm allowed to say no in surgery. I will make the decision. If I can do all the procedures at once, I will. I would prefer to, but if I can't, I'm not going to. And the owners understand that. And this is the same for brachycephalic surgery, hemoabdomen, GDV, all these diseases that require emergency surgery. Pet owners say, by the way, while you're there, can you do this and this? And I say, well, maybe, depends on what the pet is doing. So that's a common scenario that I see as well. As a general practitioner, yeah, I'm a fan of you performing these procedures. I would say, practice on a cadaver. Make sure that you're comfortable with the anatomy and what you're going to do. You don't have to do this procedure with specialized equipment, although if you are performing a lot of these, you may want to invest in specialized equipment to become more efficient. And of course, you should charge financially for that, of course. But as a general practitioner, as long as you feel as though you can practice on a cadaver and communicate with the client effectively, I'm a fan of doing these. Especially if you live in an area that's very rural, where you don't have surgeons around. You may have to do these procedures, and so dive into them and practice. Post-op care in the hospital, we discussed a little bit about this, but one of the things I typically see with general practitioners who perform high-level surgery is not the surgery that is great. The post-operative care is not great, and so you want to make sure you're set up for constant monitoring of these tests, blood pressure, ECGs, making sure you're checking pulse ox. Do you have oxygen available? Who's monitoring these patients? Maybe you're performing the surgery and then transferring them to an emergency hospital, right? Whatever it may be, but a great surgery can fail because of poor post-operative care. So just keep that in mind. I'm a fan of not necessarily rechecking these patients. I don't want to see them unless I have to. So usually what I'll do is the owner will call me 2 weeks after surgery and tell me how things are going. Maybe they can send you a video of how the pet is doing. But to have a dog that's already high anxiety come to you, and the only thing I can evaluate are the nares. I can't see the upper airway without sedation, which I'm not going to sedate them at the recheck if they're doing well. I don't really need to see them again. And so I'll do a recheck over the phone or over video instead. So you can keep that in mind as well. And then in this whole conversation was based on dogs. Cats I have no experience with. They're not the same as dogs though, especially when it comes to their nares. So if you're going to dive into this world of surgery, cats are different. And so you want to talk to a surgeon or a general practitioner who has experience with brachycephalic cats. So it's a different ordeal. They're much more difficult, especially when it comes to the stenotic nares. So a couple of key points that I want to touch on before we have any questions. Client communication is key. What I talk to the pet owner about when they come to me with this disease, I want to set the stage for their expectations right from the beginning. And I tell them that this brachycephalic syndrome, there are repairable things and there are irreparable things. There are some things in your dog that I can fix. There are some things in your dog that I can't fix. And if things don't go well, and the best I can do with what I could repair is the irreparable stuff that's contributing to the problem, right? Because if I can't fix hypoplastic trachea or laryngeal collapse, but all the other surgeries run really well, and the patient's coming back to you with problems, it's not the surgeon. The dog has multiple diseases that I can't fix. And if you talk about this with the pet owner right from the beginning, they understand there's one category of repairable, one category of irreparable. And we're going to do the best we can to tackle the fixable stuff, the repairable things. And that's a nice way of not confusing the pet owner with all these different diseases. You can categorize them into two separate categories. Keep in mind, gastrointestinal disease in these dogs is probably a lot more common than we think. So make sure to do a deep dive in the history to see if they have concurrent GI disease. And then, of course, you want to tailor the surgical repair to the case. I don't repair every single part of Brachycephalic Airway syndrome. For example, the everted, the saccules, I don't necessarily treat those all the time. And so it just depends on the case. You don't have to tackle every single abnormality they have. We have to be aware that they have these abnormalities. One final thing I wanted to mention before I end here, what I found helpful is after the elongated palate surgery is resected, I'll take a hemostat or Allen's tissue forceps, and I'll take an ice cube, and I'll wrap the ice cube in gauze, and attach it to the hemostat or the Allen's tissue forceps, and I'll put it on the palate. And I'll have that in the mouth with the technician recovering the dog for no more than 10 minutes, maybe 5 to 8 minutes. And that cold compress on the surgical site, I find helps to reduce the edema, the swelling after surgery. So something to keep in mind if you perform a lot of these and you're dealing with a lot of swelling post-op, it's nice to attach an ice cube surrounded with gauze and attach it to the forceps and put it on the palate surgical site while the dog is recovering. Of course, you have the technician there watching that. You have to remember to remove it, obviously, but it's a nice trick that I have over time that I like to use. So just wanted to mention that for those who perform a lot of these. This is my contact information for anybody who has any questions or wants to reach out. If you want to learn more about veterinary, of course, feel free. And I'm happy to take any questions folks have. Thank you so much.
There's a few questions on the chat, so we'll go to those first, and then if there's enough time and who wants to ask the question can go ahead. So the first question is about pterygoid bone deformities. Have you seen patients with that, and what's your approach?
Oh, okay, yeah. So I've read about pterygoid bone abnormalities in the literature. I have not myself experienced that at all. I'm curious to know the person who asked the question if they do anything with that. Do they remove surgery, or is it just an abnormality that you're noticing? I don't have any experience with it other than learning about it in the literature. I don't know.
Okay, there is also another question about palatoplasty and using the folded flap technique.
Yeah.
What's your opinion on that?
Yeah, so in the proceedings that you have, I have a comparison of all the procedures you can perform for elongated soft palate. I only went through the cut and sew, ligature, harmonic scalpel, and the CO2, but there are other procedures that surgeons like to use. I don't have the experience with it myself. However, the literature does do a pretty good job at comparing these things. And I think in the right hand that procedure works well. But from when I'm reading the literature anyway, not from personal experience, surgeries with like the CO2 laser tend to work way better because they're faster with less comorbidity. Having said that, maybe not every case is amenable to CO2 laser or ligature, and so something like palate might be a benefit. But in my hand, I have not performed the procedure before, but your proceedings, I do outline the literature on that. Great question.
Okay, one more before we take the one from the floor. It's about silicone stents, laryngeal stents.
Laryngeal
I
stents.
think you spoke about the tracheal stents, but
Yeah.
what about laryngeal stents? Is that something you
It's a great question. So I'm not familiar with it. I'm curious if anybody's ever actually tried laryngeal stenting. I have not. I have no experience with that. I can't even remember if I read about it in the literature or not. I'm not sure. But if anybody wants to contribute to that, I'm happy to hear you out. No, I have no experience with laryngeal stenting either. Yeah.
Yeah, you can go ahead and answer.
Great question. So advanced.
Thank you so much, Doctor, for your really good lecture. I'm from London. I work in the charity practice of the RTCA. We're seeing more of these dogs that we need to rehome, so we're doing surgery more and more. I was just wondering, at what point would you consider not justified to do the surgery in a stray dog when concurrent conditions? Is there any cutoff? Second question, some of the dogs, like we don't have ownership of, so we can only have consent to do procedures if they're justified in welfare grounds. If, for example, you have an elderly dog with concurrent conditions in grade 4 BOAS, so it's not going to give out either way, would you still feel that the dog would be under your possession for maybe 6 to 12 months when it goes to court? Would you still think that there's a welfare case for doing surgery rather than just leaving the dog?
Thank you. So, okay, so a lot there. So, in terms of a cutoff, when you perform surgery or not, and let's say it's a stray dog, it's unowned, what do? That's tough to say. So, in an ideal world, you would work up every single aspect of that dog's problem. And so, if you have a dog that's got Brachycephalic Airway syndrome and cardiac disease, they need a workup. You need to work up to figure out what's going on. And assuming that they're owned animals, then you have the finances and the diagnostics to perform it, you're going to want to work up every single part of their abnormalities. You want to know whether or not the cardiac disease prognosis is so severe that maybe it's not worth investing in the airway surgery. Or maybe you can stabilize with medication, control the cardiac disease, and then get them more stable for surgery if you have the fortune of doing that if the pet is stable enough. So that's a tough one. If you don't have the finances to our client who owns that dog, that's a tough one to say otherwise, because then you either are looking at doing the surgery just to see what happens, and then hopefully that dog is now adoptable, or you're euthanizing that. Or maybe there's an in-between where you're trying medical management, unless the dog, of course, is critical. So that's a tough one without actual diagnostics. But in general, as veterinarians, our job is to, if we have a situation of a client-owned pet and they have all these abnormalities, you want to tackle each one of those abnormalities ideally, and that's going to involve diagnostics to figure out what what the severity of every problem is, and then talk to the pet owner about that. But if they're strays, they're not owned, that's a tough one. That's going to come down to whatever your individual regulations or individual protocols are for those dogs. I don't want to give up on the animals, of course, nobody does. But if they're so severely affected and you're trying to get them adopted or something like that, that's a tough one. Because now you have a dog that's got all these comorbidities that maybe needs medication for life, maybe needs multiple surgeries. That's a tough one. Yeah. And I'm sorry, I can't remember your second question now. Shoot. Well, can you summarize your second question? I'm sorry.
Yeah, it was about, say you've got a dog and you're in possession of the dog for 12 months, but if you don't have consent because it needs to go to court. But the dog's like, would you consider it justified to perform the surgery on welfare grounds?
Oh, I see. So you have a dog. Okay, I see. So you have a dog that's not owned, but it's afflicted by these conditions. At what stage would you perform? At what stage would you intervene ethically, right, without having any formal consent because the dog is unknown? So at least in the United States, the rule is you have to perform life-saving measures. So let's say, for example, somebody hits a dog that's a stray, or we don't know if it's owned. They bring the dog to the hospital, and they're like, "It's not my dog," and they leave. And now you have a critical dog. At minimum, legally, at least in the United States, you have to perform whatever is considered life-saving measures. And so that's up to you as a doctor, but at minimum, that's the case. So unfortunately, with Brachycephalic dogs, if they're in a life-threatening situation, it may be that the life-saving measure is the surgery itself, right? And so in that case, it's going to come down to similar to what I said before, where it's like, what are your individual protocols for that? You have to be humane about it, and somebody has to make a call. I assume that somebody in that scenario technically owns the dog, whether it's government or the hospital. Somebody has to make a decision on that, and they ought to use the judgment of the veterinarian to decide what should be done, knowing what the short-term and long-term requirements are of it. But at least in the U.S., you have to legally at least perform life-saving measures. That's what you're required to do. That can be something as simple as just IV fluids and oxygen, or it can be like he needs a splenectomy for hemoabdomen, and that's a very different Scale, yeah, that's a tough one. Yeah, it's a tough one.
I'm going to put the last two questions together, and that's all that we'll have for this session. The first one is, have you seen reoccurrence in clinical signs post-surgery, especially in animals that have gained weight? And the second one is about complications of electrosurgery. I know you spoke about, some of the things that, aren't so nice to do with the cutting soap, but what about electrosurgery? Have you seen, any issues? And you have to stitch also, like after you do the electrosurgery, you still go back and stitch.
So I'll answer the second question first. So the question is, with elective surgery, whether it's ligature, harmonic scalp, or CO2, do you see any complications with that, or any additional ancillary procedures you have to perform for that? So the main complication I see is postoperative edema, swelling, because of the collateral thermal damage. That's the most common thing that I see. That's why I started doing the ice packing thing with the hemostat, because I thought that would help decrease the swelling, and I think it does. Otherwise, I've never performed a ligature surgery, for example, on a palate and had to sew over it. I have not had to do that yet. If the palate is too thick, it's for a ligature or CO2, then I'm going to go to the manual cut and sew. It's just too thick. That's when you see those really old bulldogs that have this condition. And the first question, in regards to, do you see postoperative signs with dogs who gain weight? So weight gain, of course, we all know is deleterious. It affects the entire body. But specifically as a surgeon, because I don't see a lot of these rechecks after I perform the surgery, because they go back to the family veterinarian, I don't know. But I'm willing to guess that yes, it would be a problem. A weight gain, obesity in dogs affects the entire body, including the airway, and so I'm willing to bet that the laryngeal area, the weight gain, and the intrathoracic fat that probably are developing from gaining weight is going to be a problem for these dogs. But I haven't seen it because as a surgeon, I typically don't have long-term follow-up with these cases. They go to their general practice for a long-term follow-up. But I can guess that probably would be a problem. Yeah.
Hey, thank you so much. If there's one more burning question from the floor. Okay, please do go ahead.
Hello? Yes, I can hear you.
Com relação à paralisia de laringe, qual das técnicas o senhor indica para a correção? A retirada parcial ou a lateralização? Ou se existe algum motivo técnico para usar um ou outro?
So the question is, thank you. The question is for laryngeal paralysis. So actually, I have a whole talk on laryngeal paralysis as well. If anybody's interested in that, I do have a YouTube channel that you can. Where is it? There you go. I have laryngeal paralysis electives, but the question is, what techniques do you recommend for laryngeal paralysis? So the majority of the cases I've only done the tieback, right? Rhythmoid lateralization. That's what I've done in all of them. For cases that don't do well after tieback surgery, and then I will consider either, depending on why it failed, you either do the other side, or you need now a partial rhythmoidectomy. That's after you've done the tieback already. So the majority of cases, I'm doing the lateralization procedure, unless there's a problem with it. And typically, if there's a problem, I usually see it like long-term, where the operated side fails, and then I have to operate the other side. If you've then done both sides and it still fail, then partial rhythmoidectomy is going to be the way to go. We do know in the literature that the wider the opening, of course, the more likelihood of bronchopneumonia postoperatively. And you see the bronchopneumonia development for dogs that have bilateral partial rhythmoidectomies is like 90%. So it really devastates them long term. So you want to try and be as minimally invasive as possible, which I think probably most people, the tieback is going to be the least invasive of the others. But there are many different options that you can perform either on their own or in combination for dogs with laryngeal paralysis. But as a surgeon, my first go-to is the tieback. Yeah.
Okay. Thank you so much, Dr. Davis.